Welcome back, fellow mitochondriacs, to an episode of Cancer as a Mitochondrial Metabolic Disease. Radiation therapy works better when oxygen is present, but many tumors are hypoxic, meaning they exist in a low oxygen environment that can make them harder to kill. So what if, before radiation, we could temporarily change the tumor microenvironment and make it more oxygenated? That's where Carbogen comes in. Carbogen is a combination of oxygen and carbon dioxide that has been studied for increasing tumor oxygenation, lowering FDG uptake, and improving radiation response. And the carbon dioxide part is not random. It may actually help blood vessels deliver more oxygen effectively. Today, we're going to break down whether Carbogen can make cancer cells more vulnerable to radiation and help starve cancer cells of glucose. So without further ado, let's get into it. So this video is going to be about Carbogen and what adding Carbogen can do to our chances. And so I'm going to start out with this paper that was published in January of 2019, and it's titled Tumor Oxygenation and Cancer Therapy, Then and Now. And it says in the abstract, tumor cells existing in such hypoxic environments have long been known to be resistant to anti-cancer therapy, long as in more than 100 years, display an aggressive phenotype, and promote tumor progression and dissemination. This review discusses the physiological basis of hypoxia, low oxygen, methods of detection, and strategies to overcome therapy resistance. And from this paper, I pulled this blurb about Carbogen. So it says here, 100% oxygen breathing has been shown to elicit deleterious and toxic effects in the body, mainly to the central nervous system, lungs, red blood cell, morphology, peripheral vision. That's like extreme long exposures to oxygen. We'll talk about those dangers and possible risks in the future. Furthermore, in a response to this level of oxygen, arteries and arterioles actively vasoconstrict or clamp down. To mitigate the latter, Carbogen, 95% oxygen, 5% CO2, was introduced as an alternative breathing gas. Indeed, preclinical investigations demonstrated that Carbogen improved tumor oxygenation and response to radiotherapy. In the clinic, Carbogen largely, and somewhat surprisingly, did not demonstrate improvements in radiotherapy outcomes. We'll look at papers where it did. However, a trial using Carbogen breathing in advanced head and neck cancer patients did suggest that Carbogen breathing may be an alternative for patients who are unfit to receive concomitant chemotherapy with the radiation treatments. Preclinical investigations have shown that Carbogen effectively reduces chronic hypoxia in tumors, but has little or no impact on acute hypoxia. Nicotinamide reduces acute hypoxia, though the mechanism remains unknown. Thus, to overcome both types of hypoxia, nicotinamide and Carbogen breathing were evaluated in combination. In preclinical tumor models, the combination showed substantial improvements in radiosensitivity by reducing both acute and chronic hypoxia. However, it is important to note that these improvements were time and dose dependent, making the duration of breathing Carbogen and the dose of nicotinamide and the timing of radiotherapy crucial to the therapy's success. When evaluated in the clinic, combining Carbogen and nicotinamide with conventional or accelerated radiotherapy protocols in bladder and laryngeal cancer demonstrated improvements in outcome. However, despite showing promising results, the clinical usage of Carbogen as a means to improve tumor oxygenation has fallen out of favor, or it never fell into favor, or people have no idea about it. So let's take a look at how Carbogen stacks up to just regular oxygen therapy. So this top kind of row is looking at the gas mixture. Okay, so here's room air, for example, 21% oxygen, 79% nitrogen. And then you'll see increasing amounts of oxygen, respectively, right? And then you're going to hit a barrier of 100% oxygen, 0% nitrogen. And then where Carbogen comes in is instead of having 100% oxygen, 0% nitrogen, or 93% oxygen, 7% nitrogen, we're going to use 95% O2 and 5% CO2. And then it's going to look at, what it does to actually your arterial kind of oxygen in millimeters of mercury, hemoglobin saturation, dissolved oxygen in plasma, tumor oxygen potential, effect on blood flow, and the clinical rationale. And so I'm going to start off this talk as a continuation of the prior talk, talking about how hyperoxia without pressure has been shown to decrease FDG uptake on PET scans. And this paper was published as early as February 2006, and it's titled The Influence of Tumor Oxygenation on 18F FDG Fluorine 18-deoxyglucose uptake, a mouse study using positron emission tomography, PET. And it says here in the abstract, however, when in only the highest 18 FDG uptake regions of the tumor were considered, small VOIs there was a modest 21% but significant increase in the air carbogen ratio, suggesting that these potentially most hypoxic regions of the tumor, 18 FDG uptake and hence glucose metabolism, may be reduced by increasing tumor oxygenation. We're going to see exactly how much in other studies as well. It says later in the paper, however, only the highest FDG uptake region of the tumor were considered perhaps the most hypoxic regions. The hypothesis was supported. In the presumably metabolically active regions, there was a small 21% significant increase in the air carbogen uptake, suggesting reduced FDG uptake under conditions of better oxygenation. And there is a more recent paper that was published in 2015 and is titled, "The increase in tumor oxygenation under carbogen breathing induces a decrease in the uptake of 18F fluorodeoxyglucose. We observed a significant drop in 18F fluorodeoxyglucose under carbogen breathing that suggests a rapid metabolic adaptation to the oxygen environment." And you see here that the FDG uptake at the most hypoxic parts of the tumor is, let's say, somewhere between 3 and 3.5 on the scale. And as soon as they got above 10, so they doubled the amount of oxygen at 10, it now is hovering around 2, and it kind of just leveled off after about 25, 30 millimeters of mercury. I would have liked to see them go higher, and I'll tell you why in a minute. So here's another paper, even more recent, published in November of 2019, the effect of carbogen breathing on 18F FDG uptake in non-small cell lung cancer. And basically what they did is they had these animals breathe in carbogen at 95% FiO2 or oxygen and 5% CO2. They had them breathing this carbogen or room air for a period of about 120 minutes. And so basically what they did was they had these mice with this non-small cell lung cancer breathe either room air or carbogen. And 60 minutes into the breathing of either gas, they got an FDG injection, and then the PET scan was done an hour later after that. And so we see here, I'm going to start with the normal tissues. So here's the normal tissue. If you got air, there was, X amount of FDG uptake. And then if you got carbogen, there was a slight increase. Same with lung. This is normal lung. This is liver, muscle, heart, gut, nearly the same, really, for most of these normal tissues. However, what do we see when we look at the tumor? So here's air, right? Here's FDG uptake at about 10. And then you see that if the mice got carbogen, it decreased the amount of glucose uptake, this radioactive glucose, this FDG, by about 50%. In fact, it's 57% is what the paper actually shows. Astounding. And again, this is not such a hard leap for us to make when we know the mechanism of why glucose and glutamine uptake in tumors is increased. It's increased, at least in a major part, by these hypoxia-inducible factors. So you'd imagine that if there's less hypoxia, then these hypoxia-inducible factors are not having the same amount of action, and that would lead to a decrease in both glucose and glutamine uptake. Now, this study is only looking at glucose, but we saw from the prior video how hyperoxia can also decrease glutamine uptake as well in other studies. But the question is that the mechanism is all good, right? But the real question is, how much does it actually decrease the uptake, right? It's nice to know, okay, HIF1, glucose transporters, on a graphic like this, it's very cool. But at the end of the day, by breathing in carbogen, what happens, right? Like, what change is there? And it's substantial, 57% decrease after 60 minutes. So this is just another paper from 2018 titled Hemodynamic Effects of Acute Hyperoxia, Systemic Review and Meta-Analysis. And it's basically just saying how hyperoxia may considerably decrease cardiac output and increase systemic vascular resistance, but effects differ between patient categories. And it's just kind of confirming another source that when we give hyperoxia or high percent oxygen, then there is a physiologic vasoconstriction or clamping down of the blood vessels that happen. So the idea behind carbogen is to help try to mitigate or prevent that. So let's circle back to radiation therapy. And there are oxygen tensions or oxygen amounts in these tissues that makes these tissues that are shot with radiation either radio-resistant because of the hypoxia or radiosensitive because they're more normoxic. 20, 30, 40 is very likely still hypoxic compared to what is normal in tissues, but it's sufficiently normoxic where radiation therapy is more sensitive. So let's take a look at the first study that was published in August of 2019, and it's titled Carbogen Inhalation in Cervical Cancer, Assessment of Oxygen Change. And it says here, the average median PO2 or oxygen increase went from 8 millimeters of mercury. Okay, so 8 millimeters of mercury is in the radio-resistant range, right? And after a 4-minute treatment, it went from 8 to 96. Okay, that is actually off the charts on this table of showing that it's solidly within range of being radiosensitive. Pretty awesome. The next paper was published a couple of years later in February of 2001, and it's titled A Pilot Study Comparing Intratumoral Oxygen Using a Comet Assay Following 2.5 and 5% Carbogen and 100% Oxygen. And basically what they did is they compared what happens when you give 100% oxygen versus 2.5% CO2, which is like a half Carbogen, and 5% CO2 and Carbogen. And you see that no matter what we do, whether it's oxygen at 100% or 2.5% oxygen, 2.5% CO2 or 5% CO2, there's a massive increase in improvements seen on these graphics and these calculations they make of being radiosensitive. It's just that the Carbogen, because of the 5% CO2 and overcoming that vasoconstriction, has even a more effect than 100% oxygen. Now, it's not always like that. In fact, this paper here that was published in January 2002 kind of puts a little bit of a blanket on that data, and it's titled Dynamics of Tumor Oxygenation and Red Blood Cell Flux in Response to Inspiratory Hyperoxia combined with different levels of inspiratory hypercapnia, or CO2. And it says here, mean PO2, or mean tumor oxygen status, increased 3.6-fold with 100% oxygen, or pure oxygen, or 3.3-fold if you added 1% CO2, and 2.7-fold if you increased it to 2.5% CO2. It would have been nice if it actually showed what 5% would have been. The conclusion was higher inspiratory CO2 fractions, 2.5 and 5%, lead to a prolonged improvement in tumor perfusion after the inspiratory hyperoxia compared to the pure oxygen. But so basically what they're saying is that the hypercarbia, or the high amounts of CO2 seen in Carbogen, had a prolonged effect after you were done breathing it in. But in terms of the actual oxygenation in the moment of breathing, it seemed like the pure oxygen was actually slightly better. Let's look at some studies that were done. This is published in May of 2012, Accelerated Radiotherapy with Carbogen and Nicotinamide for Laryngeal Cancer Results in a Phase 3 Randomized Trial. It says a 5-year regional control was significantly better when they got the ARCON, 93% versus AR. So first, let's define some terms. AR just stands for Accelerated Radiotherapy, and ARCON stands for Accelerated Radiotherapy, but they're getting Carbogen and Nicotinamide. And so at 5 years, the regional control was better with the Carbogen and Nicotinamide, 93% compared to the radiation alone at 86%. The improvement in regional control was specifically observed in patients with hypoxic tumors and not in patients with well-oxygenated tumors. Find a tumor that's actually well-oxygenated. I'd like to see it. 100% versus 55% respectively. And AR and CON produce equal levels of toxicity. So there was no increase in toxicity or even improvements in toxicity if you got Carbogen and Nicotinamide comparing the two. This is what I thought was very interesting. First of all, it wasn't even full Carbogen. It was actually 98% oxygen and 2% CO2. So it wasn't even the full 95-5% ratio. But this is what really got me. They only gave 4 minutes of Carbogen breathing, improved 5-year regional control from 93% to 86%. 4 minutes. Pretty unbelievable. The next study, published in 2014, improved recurrent-free survival with ARCON for anemic patients with laryngeal cancer. And it says here later, however, in patients with low pretreatment hemoglobin levels, ARCON significantly improved 5-year local regional control, 79% versus 53%. Now it's starting to break away, right? And disease-free survival went from 68% if you got oxygen and nicotinamide versus 45% if you didn't. And again, this study, they used a 4-minute treatment of 98% oxygen with 2% CO2 for 4 minutes during their radiotherapy. pretty astounding. Now, one thing I didn't mention the last time in both studies, they did give the oral nicotinamide at 60 milligrams per kilogram, 1 to 1.5 hours before each dose of radiotherapy in both studies. So it wasn't straight up Carbogen only, it was Carbogen plus nicotinamide as well. So what can we actually take away from this video? First off, I don't think most people, unfortunately, are going to have access to Carbogen. It's mostly an academic exercise to hopefully maybe push conventional doctors adding Carbogen to radiotherapy, because we know that having a tumor go from 8 millimeters of mercury to 96 millimeters of mercury when you breathe in Carbogen for just 4 minutes has shown improvements in outcomes when it's been studied. We know from 100 years of research that hypoxic tumors are radioresistant and normoxic tumors are more radiosensitive. And kind of putting this in context of cancers and metabolic disease, we also know that when we give oxygen, whether it be 100% oxygen or higher percent oxygen without CO2 added, or if we give Carbogen, we also know that it's going to have significant effects on that tumor being able to uptake and utilize glucose, one of the primary fermentable fuels that cancer use for their replication, growth, and maintenance of redox homeostasis. And as we saw in the last video, although these papers are only looking at glucose, by increasing oxygen, we are also decreasing glutamine uptake and utilization as well. So we are now with oxygen therapies covering both glucose and glutamine, as well as providing oxidative stress and other signaling pathways that we will also look at. If you like videos like this, please like, share, and subscribe. And until next time.